Room 4 has been quiet for 11 hours. This is not unusual. The patient in room 4 was brought in by ambulance at 2 in the afternoon. Unresponsive, no identification, no next of kin on record, no apparent trauma. The paramedics who brought him in said they found him on the county road 7 miles east of town, lying in the ditch, and that he had been unresponsive for the entire 12-minute drive. His vitals on arrival were wrong in ways that Dr. Okafor described as inconsistent, which is the word doctors use when they mean they cannot explain what they are seeing, but they are not ready to say that yet. You are the night nurse at Harlan County General. There are 41 beds in this building. 19 of them are occupied tonight. You are one of 2 nurses on duty. The other is Sandra, who has been here 23 years and has the specific stillness of someone who has seen everything this building can produce and filed all of it correctly. Dr. Okafor left at 9. The on-call physician is Dr. Reyes, who is sleeping in the break room and who you have not needed to wake in 3 hours. You check room 4 at 2:17 in the morning because it is on your rotation, and because the monitoring equipment attached to the patient has been producing readings that the equipment was not designed to produce. Not alarming readings. Readings that fall outside the parameters the equipment considers worth alarming about, which is different from readings that are fine. The patient's core temperature has been declining at a rate of approximately 0.3 degrees per hour since admission. His heart rate has been holding at 31 beats per minute for the last 4 hours without variation, not declining. Not fluctuating. 31. Exactly. For 4 hours, you stand in the doorway of room 4 and you look at the patient and you do a visual assessment the way you have done thousands of times in 11 years of nursing, and what you observe is a man who appears to be in his mid-40s, unremarkable build, no visible wounds, no visible swelling, skin that in the fluorescent light of room 4 has a quality you do not have a clinical term for. Not pale, not gray, something between the two that you have not seen before. His eyes are open. You did not notice this immediately because the eyes are not moving. They are open, oriented toward the ceiling, and completely still. You have seen patients with eyes open in unconscious states. This is not that. The eyes of an unconscious patient have a specific unfocused quality. These eyes are focused. They are looking at the ceiling with the specific directional attention of someone who is looking at something. You step into the room. You say his name, which is the name on the intake form, which is John Doe because there was no identification, and which is the name no one actually expects to work. You say it anyway because it is the protocol, and you follow protocol because protocol exists for the moments when your instincts and your training are telling you different things and you need a third option. He does not respond to his name. You move to the bedside and you check his pupils with your pen light. They do not react to the light, not sluggishly, not asymmetrically. They do not react at all. Pupils that do not react to light are a neurological finding that carries specific implications, and you are running through those implications as you are doing the assessment, and none of them explain the heart rate monitor, which is still reading 31 beats per minute and has been for 4 hours and 11 minutes. You reach for the call button. His hand closes around your wrist. Not fast. This is the detail that stays with you afterward. The detail that your brain returns to again and again in the weeks that follow, the specific quality of not fast. It was not a sudden grab. It was a closing, measured and deliberate, the specific movement of something that has made a decision and is executing it without urgency. The grip is cold in a way that hands are not cold. Not the cold of poor circulation or low body temperature. Something underneath temperature. You do not scream. You have been a nurse for 11 years, and your instinct in a patient situation is always assessment before reaction. And that instinct is working exactly as it was trained to work, which is the only reason you do not scream. You say clearly and calmly, "I need you to release my wrist." He releases your wrist. His eyes move for the first time. They move from the ceiling to your face, and they find your face with a directness that should not be possible in someone with non-reactive pupils in a room with fluorescent lighting. They find your face, and they stay there. You back toward the door. He sits up. Not the way patients sit up. Not the slow, effortful movement of someone recovering from unconsciousness, using arms to push, recruiting muscle groups in sequence, adjusting to gravity and blood pressure and the specific physics of a body reorienting itself after stillness. He sits up the way a hinge opens, in a single motion. without apparent effort, without the monitoring leads that are still attached to him registering any change in heart rate. 31 beats per minute. You are in the hallway. You do not remember making the decision to be in the hallway. You are there, and the door to room 4 is between you and the patient, and you have your radio in your hand, and you are pressing the call button for Sandra before you have consciously decided to do that either. Sandra's voice on the radio is the voice of someone who has been a nurse for 23 years and has heard everything. She says, "What do you need?" You tell her room 4, and you tell her the patient is conscious. You tell her the pupils are non-reactive and the heart rate has not changed, and he sat up without any change in the monitoring, and he grabbed your wrist and then let go when you asked him to. Sandra is quiet for 3 seconds. She says, "I'm coming. Don't go back in." You stand in the hallway outside room 4 and you listen. Inside the room there is no sound, not movement, not the specific sounds a conscious person in a hospital bed produces. Sheets moving, breathing, adjusting. The small physical inventory of a body reorienting to wakefulness. Nothing. 31 beats per minute on the monitor in the hallway display, and nothing else. Sandra arrives in 40 seconds. She looks through the window in the door at the patient, who is sitting upright in the bed, hands in his lap. Eyes oriented toward the door, and she looks for exactly 4 seconds with the expression of someone running a very fast and very thorough assessment. She says, "Wake Dr. Reyes. Don't use the room radio. Use your cell. You call Dr. Reyes." He answers on the second ring because doctors on call in rural hospitals learn to answer on the second ring. You tell him what you told Sandra. He is quiet for longer than Sandra was. Then he says, "I'll be there in 2 minutes. Don't open the door." He arrives in 90 seconds, which means he was already moving when he said 2 minutes. He looks through the door window. He looks for longer than Sandra did. Then he takes out his phone and he makes a call, and the call is not to another physician, and it is not to the hospital administrator, and when the person on the other end answers, "Doctor." Reyes says only, "This is Harlan County General. We have a code 17. You have worked at this hospital for 4 years. You have never heard the term code 17? You ask Dr. Reyes what code 17 means." He puts his phone in his pocket. He looks at you with the expression of a man who is choosing his words very carefully and who has been trained to choose them carefully in exactly this situation. He says, "It means we wait." He says, "Do not open that door." He says, "Do not use the hospital radio system for anything related to this patient." Through the window, the patient in room 4 is still sitting upright. His eyes are still oriented toward the door. The monitor reads 31 beats per minute. He has not moved. He is not moving. He is waiting with the specific patience of something that is not in a hurry. And the response team arrives at 4:47 in the morning. 3 vehicles, no markings, 7 people in gear you do not have names for. They do not introduce themselves. The person in charge, a woman who moves with the efficiency of someone who has done this before, goes directly to Dr. Reyes and speaks to him for 45 seconds and then turns to you and Sandra and says, "You will need to come with us for a debrief." It is not a question. In the debrief room, which is the hospital conference room on the 2nd floor, there is paperwork. Standard incident forms. The woman who is in charge fills in most of it herself, including the field that says patient classification, which she fills in from a drop-down list on a pre-printed form that already has categories on it. You see the form before she closes the folder. The drop-down field has options printed on it. Multiple options. One of them has a check mark beside it. The form was printed before tonight. The category was already on it. You ask her how long this protocol has been in place. She closes the folder. You ask her how many hospitals have these forms. She slides a non-disclosure agreement across the table. You look at the agreement. You look at her. Through the window of the conference room, you can see the parking lot where the 3 unmarked vehicles are still parked and where the 7 people in gear you do not have names for are moving with practiced efficiency and no urgency whatsoever. You sign the form. You drive home at 6 in the morning through empty county roads, and you pass the spot 7 miles east of town where the paramedics found the patient. And you do not stop, and you do not look at the ditch, and you drive at exactly the speed limit, because that is the kind of morning it is. The hospital called you 3 days later to say that the patient in room 4 had been transferred to a specialist facility and that the incident had been classified as a medical anomaly pending further review. and that you should not discuss it with other staff. They use the word transferred. You have been a nurse for 11 years. You know what transferred means when it comes with a non-disclosure agreement and 3 unmarked vehicles and a form with pre-printed categories. It does not mean transferred.